The Open Therapy Institute is addressing bias in mental health care. Go to our website, opentherapyinstitute.org. We have CE credit workshops about overlooked issues in the field. You can go to our workshop page and register now and become a member. And for those looking for a therapist, we match people with someone who's highly skilled and truly open. Just contact us through the contact page on the website or email us at info@opentherapyinstitute.org. Hello, I'm Leslie Elliott Boyce, and I'm speaking with Dr. Andrew Hartz of the Open Therapy Institute. And Andrew, I am curious on your thoughts about prescription drug treatment for routine psychiatric care. So I know this is a really complicated topic, and it's not going to be easy to pin it down to one thing, but it's an issue that a lot of people have been talking about recently. We know a lot of people use drugs like antidepressants and anti-anxiety medications. And there's growing concern about that in some circles. We've heard more news reports about it lately. And I just wonder kind of what is your general thought on this and the scope of how you've encountered this in your work?
Yeah, yeah, I think there's more conversation about what are these drugs and how do they work. And, there's a wide range of concerns that people have that they won't really address a problem, that they could lead to new problems. For example, like you take medication for ADD, it interferes with sleep. So you take a sleep medication, maybe your sleep isn't restful, you have more stress, and then you're on another medication. And so I think there's concerns about that. There's concerns about people who take benzodiazepines for anxiety, that they can be habit forming and people can't get off them. Um, Obviously, there was a huge scandal with opioids, which are, psychoactive, obviously. So I think there's a really, really wide range of concerns about them, from like subtle personal concerns about this is going to change who I am, to other concerns about risk and side effects. Um, I think it's important to acknowledge in the conversation that there are certain populations where it's hard to advocate against med use. So like somebody who has repeated hospitalizations for multiple suicide attempts and can't get out of bed and is not functional, to kind of say to somebody like that you shouldn't be able to take an antidepressant for some philosophical reason is a hard case to make. And I'm not saying that people couldn't do it one way or another, but it gets hard for some people. And maybe the most extreme case, just kind of going, it's not a medication, but it's probably the most controversial psychiatric intervention is electroconvulsive therapy, ECT. And the most of the people that get that treatment are voluntary, and it's people who have depression that just responds to nothing, and it's usually crippling depression that's gone on for years and not responded to various forms of psychotherapy, not responded to various forms of medication, and the treatment does have side effects, but it's remarkably effective at treating depression, which is why people do it. It's also used, another kind of like even more controversial use. This is probably the most controversial part of it, is it's used to treat catatonic schizophrenia. And catatonic schizophrenia, they kind of freeze up into these often like it's remarkable how people can hold body positions that seem unnatural, but they're frozen. They move at an incredibly slow speed. They often can't talk or can't talk much. On an inpatient unit, they often don't respond to medication, injections, and things like that. But they do respond to ECT
Hmm.
more. And so, but because of the catatonia, there's times where they can't consent, not necessarily that they're refusing, but they can't consent. And so I did see, and usually it was in communication with the family, that they'd talk to the person's family about like, could you like they're not responding to anything. They can be on an inpatient unit and catatonic indefinitely, or you could try ECT, but we'd have to go to in New York, you have to go to a mental health court to get a ability to do this, and then you'd see them respond.
Mm.
And so things that people in the public mind, the public tends to think that ECT is a horrific abomination, but when you actually see it change somebody's life, you can still say, I get why people have concerns about it, but the argument gets a little bit more complicated. And the same is true in other contexts. I mean, where people can have incredibly severe symptoms of different disorders, schizophrenia, bipolar, where a medication can really be radically transformative. And even if it does have side effects, you're kind of like, you can see why somebody who's well-intentioned and thoughtful about it would want to take some of these meds.
Mhm.
So I think like that's the context is like I think where on the other hand there's a real concern about overprescription, and there's a certain part of the public who I think has a mistaken belief that it's just medicine. This just treats depression. This is the medicine that treats depression and it cures depression, and you take your medicine, just like you would to treat anything else, and the medicine fixes it, and there's not a thought about, we don't exactly know the psychological mechanisms for how these work.
Mhm.
They could have unintended consequences. It's just kind of like you feel better, that's fine. And a lot of the data on the medications are like it's hard to get sometimes at a lot of the idiosyncrasies. Like drug trials tend to be 14 weeks. So you're taking a medication for 14 weeks and filling out questionnaires about how positive or negative your mood is or something. It's not necessarily profound. So if you have like, yeah, I feel happier, but off somehow, that I can't articulate, that's not necessarily going to show up in the data. And maybe it will, as kind of like patient feels off somehow, blah, blah, blah. And they're like, whatever, so it's like, what do we do with that? It's like
Mhm.
they're better. So I think so I think a lot of the subtlety gets it, because it's so hard to measure, gets put out of the conversation. So just to say, I think we're framing this in the right way, that it's a fraught and complicated topic that's portraying, and it's hard to be too sweeping when you're thinking about conditions from catatonic schizophrenia to, maybe a mild ADD. There's this huge range of what variety of different drugs are used for and the different side effects. And it's, there's a danger of like being too sweeping one way or the other.
Yeah, I see what you mean. And I guess I should say, and I don't usually do any kind of disclaimers, but it's worth noting that when we have these discussions, they're not at all meant to be medical or mental health advice. They're meant to be
Right.
conversation starters. They're
Yeah.
discussions, food for thought, things that we are talking about and hearing other people talk about that seem relevant, and that it's worth sort of sitting together and teasing apart a little bit and looking at some angles. It's not meant to be some definitive statement on any particular topic, especially not
Right.
something as complex as this kind of treatment modality. And one of the areas that I hear concern expressed is that with sort of routine psychiatric drug use, like SSRIs, benzodiazepines for anxiety, Ritalin, Adderall, sort of ADHD drugs. A lot of these are prescribed by a doctor who maybe sees the patient for 15 minutes. And they describe some symptoms,
Like a
go through
GP.
a GP. Yeah, just
Yeah.
a primary care doctor.
Yeah.
And then there's not an ongoing oversight of how that treatment is playing out for the patient. And then the patient maybe sees a therapist as well, but the therapist doesn't really have any oversight or any training necessarily on what to look for with those drugs. And so they're kind of it's kind of left to this sort of self-diagnosis, self-report by the individual person who's using that drug, who may not be kept aware of all of the secondary effects that they're potentially going to experience as a result of being on that thing long term. So So I've heard this expressed by therapists that there's a concern.
Yeah.
We hear many of our patients are on these drugs, and it's kind of
Yeah.
a black box that we don't really tread into.
There's and yeah, I think my understanding is that there's a theoretical gap of like it's not like it's not necessarily that somebody knows how all these things are working and they're not training the therapist properly per se. I think it's unclear. So like just to take the question of, and I think in psychological terms, to have a good theory of what is this drug doing. And we kind of so take like an SSRI, an antidepressant medication. Is that a mood elevator? So like whatever your mood is, 0 to 10, if it's at a 2, bump it up to a 4. If it's a 5, it'll bump it up to a 7 or something. 'Cause that's what it does. It adds 2 points or something. That would be one kind of model of what this is doing. But another model is it's kind of like a buffer where it keeps it dropping below a 3 or something. And like I heard one, he's actually a relative of mine who does research on psychopharm. He's a neuropsychologist, and he was talking about SSRIs as boosters of aggression.
Hmm.
And
Hmm.
like one theory of depression is that Freud's theory was it's aggression turns inward, that you have this kind of a self-criticism or you take abuse and internalize it. And so what the SSRI does is actually according to this theory, was that if you increase assertiveness, that you would not tolerate self-abuse or
Hmm.
abuse from others, and that would reduce the depression. But that's a pretty meaningful personality shift. And one can see how, like, if 10% of the country is taking a med that increases aggression, what might that do to society? Even if it's a small level, when you scale it up to something like that, this is going to be a different place now. And those questions are really, really hard to answer. You can kind of ask people if they think they're more aggressive or something. Um, Behavioral analysis of it, it's like those studies can become very expensive and difficult and um, not necessarily easy to do. And so there's all these basically, and all of those might be wrong, and maybe it's doing something else. But I think like for a therapist thinking about, okay, my patient was like this. Now they're taking this other drug. How does that impact them? In terms of like how I might need to shift the treatment. Like if it's working as a block against extreme negative emotions, you can kind of see how that could maybe create a problem. Like if you have a loss and you go through a grieving process. Now, maybe somebody doesn't want to go through that grieving process. They take a medication, it blocks it. But maybe there are benefits to going through that process, that you disentangle from a relationship or you recharge or something, you slow down and turn inward for a period of time where you can kind of like reconstitute. And maybe a lot of those potential benefits of going through a grieving process, for example, are lost, and you're kind of stuck with kind of unnameable bits of unprocessed grief and part of that process that never happened because you didn't want to go through it. So in the 14-week trial, maybe even in the 6 month or 2 year trial, your mood is elevated. It prevented negative mood. But you
Hmm.
look years down and there's pieces missing that you feel like you never kind of got out, maybe lost touch with, and then they're so normal you don't even notice they're there or something. I mean,
Hmm.
how do you do a study to say 10 years later there's unnameable aspects of grief that are unprocessed that might be lingering and causing ambient distress? It's like I don't know. None of that is going to be. It's just like not. Maybe somebody's better at research design than I am, but I just think that stuff is near impossible to get at. And so so it just gets kind of like tuned out. Like if it can't be measured, we really can't take an untestable, unmeasurable theory and use it to guide medical decision making. Um, but for a therapist where you're dealing with this day to day and you're thinking about how are my patients interacting with this, it is relevant. They seem better, but they're not able to process maybe certain types of negative affective states in the same way. And maybe that kind of keeps them stuck. Or they're not like a you could see how that could over time really radically change somebody's behavior. Like a breakup doesn't hurt as much. So that's going to change how what your romantic life looks like. Like you're not as worried about that, or and maybe you're more callous.
Right. Might decrease your empathy or your ability to be sensitive to other people's feelings.
Right. And so, but some of that stuff you might be able, and people are different. That's the other thing. Like people respond differently to these. So some people might have an experience like that, but maybe they're 5% of the people that take the drug. So how do you identify that 5%? Because otherwise you'd need such a huge sample to detect that. And for a medical study, I don't know. That's just going to cost a fortune and take so much time to find a little effect that affects 5%. It's so
Hmm.
I think like but to a lot of people they have this sense of like they know how it works, the doctors know how it works. This is data behind it. It's medicine, and they just take it. You get this reference to like the unnameable a little bit when you I think when you'll hear people say like about a spouse or something. Like she started taking this medication and yeah, she got better, but she's different. And they're
Hmm.
like, how? And they're like, I don't know. She's not the same person she was, but I don't know what that is. It's different.
Hmm.
And they're like, oh, I feel better. I'm so much better. And they're like, I don't know. There's something different here. Or
Hmm.
like you kind of like, but that's like that, whatever that difference is, it's like people can't even put it into words. It's really hard to say how is that going to show up on a questionnaire? How do you design a study about a variable that you can't even articulate? You really can't. So,
Hmm. Hmm. Yeah. On the topic of training, I studied psychopharmacology as a part of a neuropsychology course when I was in undergrad. I had the opportunity to take some courses with the master's level clinical psychology program at my university. And I learned more about psychiatric drugs in that course than anything I learned in my clinical mental health counseling training in my master's
mm,
program. We didn't even go into them at all. We didn't talk about
mm,
psychiatric drugs really at all. It was not even
mm.
kind of an overview of the main ones. It was sort of left off in this other category of not your domain. This is the domain of
Yeah.
psychiatry, and psychiatric nurse practitioners will be the ones prescribing these, and doctors will prescribe these. And so I there
And
was
they don't have the training in therapy. They don't understand it.
exactly,
Yeah,
that's
yeah,
kind of the
right.
thing. It seems like there's this missing piece, and some of the takeaways, you're speaking to some of the takeaways that I took from the psychopharmacology training I received, which was the drugs are sort of inherently mysterious and experimental. We don't exactly know the mechanisms of action of a lot of the drugs that are prescribed routinely. And another thing was that and my professor made sure to emphasize this. We think of things as having a main effect and side effects, but actually drugs just have effects. And
Mm,
so something like SSRIs that have frequent, we will say, sexual side effects, like
right,
anorgasmia or reduced libido, these can
right.
actually be seen as just effects of the drug. And so I think a lot of times
Mm,
people
right.
are like you said, there's kind of this foregone conclusion, this real sense of confidence in the main marketed benefits of a thing,
hmm
without a fuller understanding of what you may be getting into when you start to use this particular substance. And some of those personality altering things, they're not exclusive to things like psychiatric drugs. One of the topics that I think has been really interesting to hear more about in the last couple of years is the effects of on personality of birth control, hormonal birth control. And
Interesting.
so, when you talk about she's better, but she's different, someone whose hormone cycles necessarily make them a phasic sort of individual that goes through different phases of personality. When you freeze them in one particular phase of their hormones with a particular level in their system, well,
Yeah.
maybe that's helpful in some ways in terms of regulating, but it's also changing the nature of a lot of other aspects of the person's life.
Yeah, that's really interesting. I mean, I think what they are good at with the medical research on these drugs in terms of like side effects is they can really look at, does it increase suicide attempts? Does it create something that rises to the level of a psychiatric disorder like a manic episode?
Mhm.
Does it have major health impacts on like your heart and stuff like that? Like they do, or cognition or something. Like they do the big dangerous stuff and the main, like the kind of big measurable effects. I think they do a good job on that. I think that
Mhm.
it's quite rigorous, especially short term, but even at this point for a lot of these like long term studies. And so I do think that's worth saying. I Yeah, it's interesting that you're bringing up birth control. I One thing that really interests me is that there's kind of I think that there's like two camps about drugs. And one is like they don't like the medical drugs, but they like alternative drugs and supplements and maybe psychedelics and things like that. And then there's the inverse. And then there's some people that like both and some people that like neither. But there's kind of like um, I think it's interesting why certain people would gravitate towards, well, uh, I don't want to take an SSRI, but I will take this mushroom.
Mhm.
And um, and that's huge too. And like one thing, like first of all, just in terms of like, I feel very confident making this advice. Like, you should ask always, therapists should always, always, always ask their patients what psychotropic medications they're prescribed. Often other medications, just know what medications they're on, period. Health medications too, because like birth control or something, those things can have an effect. Um, Also, I would always, always, always ask what supplements they take and alternative medications they take. The mushrooms and these supplements that people are taking are just really wild, and they range from even something that's been used a long time like St. John's wort.
Mhm.
Like I saw studies that were showing it has a powerful psychological effect. And but patients often don't tell their psychiatrist, oh yeah, I'm taking St. John's wort. A good physician would always ask like what types of supplements you're taking and if they're taking anything like that. But like you have to communicate with your providers if you're taking that stuff because it can have interactions with the prescription medications or other things. But there's just an enormous use of stuff like that, and it's everything from CBD to microdosing to St. John's wort to like it's just and that stuff is really widely used. And that's the thing that's more dangerous about that stuff is that it's done often. The dosing can be irregular. It can have heavy metals in it. You switch brands and it's got another ingredient. You don't know what it is. It's not well, like one thing with CBD, for example, is people have to look how much THC is in it. There's usually some THC and sometimes a lot.
Mhm.
And sometimes it's not very well purified. So it's just like sloppy. So on average, it might have that amount, but from dose to dose, you're taking a different. So I think like that's stuff to be really, really mindful about, and people don't talk about that, don't talk about that stuff either.
Wow, and I'm so tempted to just branch off and ask you to talk more about cannabis use because that's, I mean, maybe that's a whole nother conversation, but it's proliferated
Mm.
so wildly in the last, what, decade or so,
Yeah.
where it was something that was a little bit more niche, and now it's legalized in a lot of areas. And from what I understand, the amount of THC that's present in cannabis that's sold over the, at these pot stores is much, much higher than what people would have found, just on the street when they were a kid.
Right.
So I know that's a whole nother
Everything.
topic, but
Oh, it's so common to see. I mean, it's everything. I mean, I get asked all the time about ketamine. I get asked all the time about psychedelics, ayahuasca. I get asked about MDMA. And people are really curious about the therapeutic purposes of these drugs. I think it's another. I think there's something about drugs in particular that, and people have this, sometimes people have this type of thinking about therapy, but I think it's less that there's a magical belief system about a lot of them that like you take the MDMA and it, you know, exercises your trauma out of your soul, through it. I think there's this, there's a sense of like, oh, this just cures it. This just like fixes everything. And it's easy to have fantasies about uh, it's almost like yeah, I mean that there's this kind of like mystical, almost like magic to it about, and I think I see it the most with psychedelics,
mhm.
which I am curious about what their effects are. I think that the research there is really interesting. I'm not, I'm very interested in it, but like the range of things that people propose that it can cure with an incredibly high effectiveness rate and virtually no risks or negative impact is raises alarms for me. I find
Mhm.
it totally implausible. We'll see, but just it just seems like there's almost this sense of you trip, it's really fun, you see lots of cool shit, it feels good, it cures everything, and it has no risks. And it's just kind of like, no. I just don't believe it at all. And
Yeah.
and but it's like, look, under a very limited situation where it's used in a particular thoughtful way for certain conditions of people who are appropriately vetted and followed up with in a context of treatment, that's a totally different thing
Mhm.
from the way people are doing it. But it doesn't, I think what's happening is there's this conversation about, oh, like there's all this data, there's the studies that it treats these things. Psychedelics are really effective treatments for A, B, or C. And then people decide to go do it with their friends. And that's how and they're like, it's treatment, but it's kind of like, it's easy to just see it's just an excuse, because you want to trip. And it's like, so I mean, and not that that's like necessarily like the worst thing in the world, but it's just like I think people want to believe
Mhm.
that, this is a silver bullet. And
What's fascinating about that is it's kind of two sides of the same coin, that magical belief that this thing is going to heal me. And,
Mhm.
well, you see that with pharmaceuticals, you see that with non-pharmaceutical like alternatives. And it kind of brings us back to the power of the placebo, the power of our mind, and
Mhm.
how, ultimately changing something about your life trajectory, changing how you feel about your circumstances or how you feel about your efficacy is, you can use tools to get you there, but the change happens in your mind and in your convictions going forward. And so I kind of wonder if a similar thing is playing out on both sides of that equation with the alternative treatments, with the mainstream treatments. You believe it's going to have this effect, and so you put it into yourself, and now you believe that you are imbued with this new this change.
Yeah.
I think it's so powerful when you study placebo and why it works. It's
Well,
kind of the
yeah,
biggest mystery.
yeah, exactly. And like for a psilocybin trip, uh I think you can tell if you got the sugar pill. So if you get the sugar
Yeah.
pill, you know. So it's really you
Yeah.
can't really blind the study.
Hmm.
Um so
There's a
I
really
mean that
interesting book on that I read a couple of years ago. Michael
oh yeah.
Pollan, it's called How to Change Your Mind.
Oh yeah, yeah,
And it
yeah.
was really interesting. He gets into some of the data on like end of life treatments, like psilocybin for terminal
Yes,
for people
yes.
with terminal illness, and it's very interesting. And I've also talked with a couple of therapists who do psychedelic therapy. It's kind of just like when you're talking about the pharmaceutical thing. There's this really, it's a very big and complex topic that has
And
a
there's
lot of people
no
advocating different sides of it.
and the theory is poor. I
Mm.
really have a hard time articulating this because it's kind of like a difficult people when they talk about when you read a lot of papers about how any of these drugs work, they often go straight to the brain and it's like serotonin, dopamine, this region or subregion or nucleus in the brain or this type of thing. They go to the brain, then maybe they'll go to hormones, they go to biology, but
Mhm.
it's not really a psychological theory.
Mhm.
As an example, like the classical psychoanalytic theory about psychedelics that I heard was that they foster ego weakening.
Mhm.
And ego weakening in the psychoanalytic sense. So your ego, as opposed to your id or superego, performs a number of different functions that are called ego functions. And ego functions have to do with knowing what's real and what's not real, who I am versus who you are. So it's self-other. It has to do with judgment, goal-directed behavior, inhibition of impulses, emotion regulation, defense mechanisms. It's the part of you that holds it together in a realistic, balanced whole as like, okay, I'm me and this is real and you're you and this is what I'm doing and regulates. Okay, that's really what the ego does. So we'll talk about, psychoanalysts will talk about a strong ego or an overly rigid ego or a weak ego. A rigid ego kind of has really ingrained habitual defense mechanisms and coping mechanisms, and it's very difficult to change.
Mhm.
And a weak ego is like unregulated, uses primitive defenses. The identity and relationships are constantly in flux, and it's doesn't quite can't quite have the judgment to know what's real and what's not real, or what's appropriate and what's not appropriate. So you can kind of see like ego strength and ego rigidity and things like this. It gives you a sense of what the psychoanalytic ego is, as opposed to I think the way a lot of people in culture think about ego, it's like arrogance or selfishness or like things like it. This is different. You need a functioning ego to work as a person in the psychoanalytic sense. So what a psychedelic would do is weaken the ego. And if you talk about what people describe as being the therapeutic efficacy of these drugs, it loosens defenses so that you can access emotions that you're defended against. It loosens the identity so that you can have some flexibility with it. People often describe an interconnectedness with other people or with nature. Their sense of reality is muddled. The difference between conscious and unconscious is often blurred. And so it's an ego weakened state.
Mhm.
And so when you think about it that way, as what do these drugs do? They weaken the ego. Now, that is it might not be accurate. I think there's some evidence indicating that this is what happens on the drugs and other, but you can actually get a handle on what is this doing in psychological terms. I'm less interested in what types of the brain are impacted, but what is this doing psychologically? And it seems like things certain things make sense. Like think about Charles Manson. You know, one of the thoughts, I'm not sure if this was confirmed, but I think this was a popular theory, was that he was able to control people by using psychedelics to remold their identities.
Mhm.
He would take that ego flexibility to reshift them to a different personality structure that saw him as God or whatever and would do anything like he would. So if that fits, that there's potentially an incredible ability to reshape your personality while on psychedelics that could be very powerful. And then that would make you think you want to be really careful and thoughtful about how you do it. And maybe if you're just out having fun in nature, no big deal, and nothing major happens, but you want to be thoughtful about what you're doing with that because you could reshape your ego in ways that might not feel good or be good for you,
Mhm.
or could be very good potentially. Um,
Yeah, it puts you in a state of a susceptibility to change, which, if
Potential.
you're rigid, has the potential to open up and change some patterns that are not serving you. But then again, like you said, that's the thing that they say with psychedelics is set and setting is everything.
Yes.
So
And,
that's why the more therapeutic setting is controlled for some of those potentials.
well, and what we know from therapy is like what is happening in that therapeutic setting in a real way. It's not just like vaguely therapeutic. What are you actually doing? And like having good theory and practice standards and formulations about what that is and like would be very, very important. And it might also mean that people with really weak egos might be poor candidates for this
Mm.
because if it further weakens their ego, which could lead to heightened dysregulation.
Confusion.
Or
Yeah.
yeah, and
Yeah.
poorer judgment and so again, that theory might not hold up over time. Most theories don't. They get modified and challenged over time,
Mhm.
but it's at least it's a theory of what's happening psychologically that helps people conceptualize treatment and how their patients are impacted. I don't see they're definitely not taught, and I don't to therapists. I think that's totally legitimate. I don't know how many are out there about theories that are similar to that about benzos, about SSRIs, about stimulants, about sleep medication. What is this doing? Or even about cannabis. Like, what is this, or alcohol? Like, what is this doing in
On the
psychological terms?
psychological level.
Yes, and
Mhm.
I think when people don't have my when when people don't have a good theory for
Mhm.
something, they go to biology. So the stuff that they people don't understand, my sense is if you don't understand it, people tend to go to biology of like autism is seen as more biological. It's not, it's often not heritable. It's not heritability. Like things that are more heritable aren't necessarily seen as more biological, but it tends to be something that people reach for when they don't understand things. But
Mhm.
I think that's why the theories here, there's no theory. People don't really understand it very well. And so whenever they talk about how they work, they go into neurons and things because, and not that look, I think it's great to understand the neurons in the brain. And I think we should keep doing that research, but the psychological theory is totally lacking. And my guess is that's a big part of why so many therapists feel at sea with this stuff is they don't have a theoretical handle about like how is this impacting my patient? How is this impacting the treatment? I don't even really know. And it's probably worth just going through a period of like detailed observation about this stuff and theory generation about this stuff so that we have a body of theories about how these work that we can then test. But we kind of like, I don't know that why that, and it seems to have not happened. And maybe it's just particularly difficult or people don't know where to start, but um, yeah. And that lends itself to like the magical thinking too. And strong opinions one way or another. It's all crap. It's all a perfect cure. It's great. Everybody should do it. Nobody should do it. It's like that just to me is like people, we don't understand it.
Yeah, and I feel like there's a particular challenge around medical like pharmaceuticals that are manufactured through our pharmaceutical industry because there's a body of expertise on that other people don't feel qualified to comment on. And so if you're outside, like if it's something like a mushroom or psychedelics, these kinds of compounds that have been in nature for forever, they're there for all of us to observe. They're sort of these emergent things. We can theorize about them. But if you're outside of that uh, process, that scientific research-based process that puts out the sheet that says this is what this does, and it is all like this biological jargon, then it's hard for somebody to crack into that from outside and start theorizing about it when they feel like they're stepping on somebody else's expertise a little bit. I don't know if you see it that way, but I think that
Mm.
might be a challenge to forming some of those concepts. And I really like where you're going with that. And I think that makes a lot of sense. One of the things I really enjoy about these conversations is that we'll start off with something and we don't talk about these before we hit record. And so we have this sort of like nugget of a thought, and then it goes in directions that I could never predict. So
Yeah.
I'm really glad you shared all of those theories about ego and psychedelics. It's fascinating to me, and I hope maybe at some point maybe we can invite uh, a psychiatrist on to talk with us, or
Yeah, yeah, yeah.
maybe a therapist who does work with psychedelics. I think it'd be really interesting to sort of flesh out some of these areas.
Yeah, yeah. And it would be worth just kind of cataloging theories in
Mhm.
psychological terms. I mean, I've had a hard time just in my field, just even making the case to people like we need psychological theory that's robust here to even start to formulate what's happening. And often it requires these um vocabularies that we don't normally use, like to think about rigidity versus ego weakness. That's a difficult concept, but I think once people kind of can represent it a little bit in their mind, they can see how psychedelics could play into that. And it kind of fits.
Mhm.
That really, like, if anybody listening to this, keep this theory in your back of your mind and ask somebody who's tripped or is interested in psychedelics or whatever, what they experienced. And it's uncanny how much it reflects ego weakening. It's almost every time you just ask people, what do you think what do you think is good about it? What works about it? And they just describe ego weakening. It's really amazing. I don't think I've heard anybody say something that wasn't consistent with
That
ego
didn't
weakening.
fit.
And all the times and when I taught it, I taught this when I used to teach, I asked people to describe it. And we got everybody describing things. I was like, this is ego weakening, by the way. This is exactly what you described.
Hmm.
Um, but it allows people to think about pros and cons and what's appropriate for use. I mean,
Mhm.
to me, there's something a little bit scary about one dose of a medication leading to permanent personality change, which is really the claim is that if these are really as effective as people are saying they are, that's what they do.
Mhm.
That's an intense intervention.
Yeah.
And I think anything with that's claiming that monumental of a change requires to be approached with some carefulness and some thoughtfulness.
Like on the level of ECT.
Well, yeah, I mean, potentially. Yeah, it's a massive thing. I wonder, and I kind of feel like if there was like we didn't have the cultural history with psychedelics that they were related to like Jimi Hendrix and stuff, it would be like, and all of a sudden the doctors came out with a new drug, and it was just like it's called, um, it's called psilocybin. It's a pill. Ask your doctor. And they did the
Mhm.
whole advertisements and stuff. I wonder if I think maybe different people would be in favor of it or something. It's
Yeah,
like
well, the
the
history of
vibes are different.
psychedelics is really interesting with the LSD and the experiments by the government. There's a great book called Chaos,
Oh,
Charles Manson, the CIA, and the Secret History of the 60s. It's by Tom O'Neill, and he
hmm.
really gets into some of that investigative journalism around what was going on in some of those ways that they actually used these drugs. They were developed and used in these really powerful ways. That's kind
Right.
of terrifying. But you're right. It's got this colloquial sort of association with fun and music and free living and art. And so
And
it's a different colloquial approach.
yeah. And one thing also about psychedelics is what's the stereotype of the old hippie who's tripped too much?
Mhm.
It's often poor boundaries, low motivation, maybe emotional dysregulation, maybe some weirdness, maybe some lethargy, maybe weird personality characteristics, poor judgment. It's a weak ego.
Mm.
It really is somebody who they're not particularly bothered by anything, but they're not particularly their ego is porous and they just kind of like they don't have as much goal-directed behavior as much. They don't have a good sense of self and other as much. They're dreamier, less connected to reality. It's this kind of somebody who's tripped too much. It's like the stereotype, at least, is somebody with a really weak ego.
Hmm.
And I wonder, the idea is maybe chronic tripping, chronic psychedelic use leads to a sustained state of weak ego, which I think is probably a state that feels good to be in, but is maybe not so great for like other people. It's not so
Interesting.
great for society because you know what I mean? Like you're not
Mhm.
as motivated, you're not as engaged, but you're in like a dreamy, great place.
Mhm.
So you don't really necessarily care that,
Right.
um, but
That's interesting.
yeah.
Yeah, it's all interesting. I think for me, the thing that I'm kind of taking from this conversation is whether it's uh, whether it's pharmaceuticals or whether it's self-administered psychoactives, there's a lot that these are complex systems that you're playing with, and they shouldn't be undertaken casually. That
Right.
this needs to be a thoughtful process, and I'm just kind of rewinding just a little bit that the piece that remains sort of I don't know. The thing that I think could be discussed further on the pharmaceutical side is that gap between the prescriber and the therapist when we're talking about a therapeutic intervention. So there's that gap still remaining, and but so many questions and so many interesting thoughts that have arisen from
Well,
this
there's
discussion.
one of the places where you see this that where there is evidence is like um for a lot of anxiety treatments like exposure treatments and stuff like that,
Mhm.
it's like benzos are very discouraged. Like you really like to really do effective exposure, not ha and I'm not saying that there aren't exceptions to the rule, but like
Mhm.
not having that. You want to kind of work through the anxiety. Um and it's really easy to imagine other treatment contexts where like maybe being off the med would allow you to work through something that then you're kind of blocked access from, and the patient might be stuck.
Yeah.
Yeah.
You talked about we talked about dissociation recently too, and as you're talking about this kind of using medication as sort of a shield to keep yourself from having to go through certain experiences, it's like maybe you don't even pass through a certain developmental process in the recovery from whatever it is that you're dealing with. I could imagine that that could even lead to more of a sense of dissociation, but that's just it's just,
Yeah.
like you say, with exposure therapy, you don't end up exposed to it. So you just kind of put it in a box and sort of compartmentalize it.
Yeah, and yeah, or you lose touch with it. And there's
Hmm.
something about the ability, like when you do, like you get a depth of maybe feeling when you fully go through these experiences. You have a depth and a wisdom that comes through that, as opposed to maybe a numb or empty or disconnected feeling, which can actually be incredibly aversive and a really
Hmm.
unpleasant
Hmm.
state. I'm also really like concerned about, and maybe this is even related to technology too, but like fragmented kind of bits of experience that we can't even really articulate, little emotional and embodied experiential fragments that are not nameable, but they're not really integrated. And even just thinking about like being on Zoom or something, and how is that different from being in person? There's these kind of little missing bits that we experience and feel or miss feeling on some level, but they're just uh, we can't always articulate what they are, but it doesn't mean that they're not active in our bodies or in our minds. Um, like thinking about this is maybe like going back to like the technology thing, but like how much of interpersonal relationships is on texting,
Mhm.
and it's like it's a totally different thing than like being with somebody in person. It's just so wildly different type of relationship. You could have like tons of friends that you text with all the time, and you're just not getting this in-person stuff. And it's like, I don't know.
Yeah,
Uh,
yeah. So
what is
many ways
that?
that life has changed rapidly.
Yeah, and like and there maybe there's a parallel between all the kinds of like psychological states that like think about like there's a type of like I kind of think of it as like channel surfing. There's something about surfing.
Hmm.
I don't know why it was called, I don't know what the etymology or origin of that word is, but there's something about flipping through content rapidly, but not really processing any of it. And you're in this kind of like semi-hypnotic state, kind of like a trance-like state,
Hmm.
um, with just kind of like stimulation without depth, that's almost disembodied, which you would get when you channel surfing. But channel surfing got annoying after like 5 minutes. You're like, I'm just flipping through this sucks. But like, but now
But
like
scrolling.
scrolling is just like you can be in a permanent state of this kind of like trance lights, like semi-stimulated, without depth, dissociated, disembodied
Hmm.
thing, and just lose an hour.
Oh, yeah. You
And
can spend hours a day
I would
doing that.
ask, I would ask like patients who are kids who are like on their phone all day. I'd be like, well, what are you looking at? And they're
Hmm.
like, I don't know. And I don't think that was just defensive
Hmm.
stuff. I think they do not know, because I'll be
Yeah.
like, what did I look at for the past hour? I don't
Right.
remember,
Right.
And so all these different like weird experiences, and I think they happen with drugs, but also maybe with technology and stuff, and they're not really, uh, um, people can't even describe what they are. Uh, but
Hmm.
they're, and like, yeah, maybe we should ask people how much what their screen time is each day, and
I
what they're
do. I
doing.
ask my clients that, how
You
much
always
screen,
ask,
yeah, oh, it's on my intake form. I talk
yeah,
about it. And how do you feel about how much time you spend on the screen?
yeah, yeah.
Yeah.
It's
I think it's a profound part of our modern landscape. And
yes.
it's another form of altered state. Like you said, I mean, it ties back into some of these things in that sense, that it's another way of altering your state, your mood, your personality, your focus.
And then you'll get kind of slammed with all the experiential bits that you were not connected with, and they feel like they come out of the blue or something. I don't know. And
It'd
then,
be
but
really
you,
interesting to hear. Maybe we can talk about it soon. Drawing from psychoanalytic theory. What are we doing when we're experiencing those little chunks of things? Where does it go? Where does it go when you're scrolling and you're seeing
yeah,
and because is it just here and gone, or is that somehow getting in? What is that doing? And I'd be interested in
yeah.
talking with you about that.
And it's overstimulated, and then people seem boring, and a lot of what it is, it's like it's a fight, and then it's like a dog, a cute puppy, and then it's like
Yeah.
a like half naked woman, and then it's like somebody yet saying something horrifically offensive, and then it's like, and you're just like, I don't know. It's
Yeah.
and then you're so desensitized to stimulation, and then it's like when you put it down, it's like reality is, I don't know.
Excruciatingly boring.
Yeah, it used to be, there used to be kind of like, you'd get up on the weekend, and like maybe you'd put on some music and drink your coffee and read something, sit down with a book, and
The
like it's just
paper. Yeah.
that was not that long ago. That was
Yeah.
in my adult lifetime, and now it's just like
It
phone,
blurs. Yeah.
phone and stimulation, and then can't sit still for 30 seconds. And but yeah, we don't for all this stuff, like there's a total lack, like I wouldn't say that's an overstatement. There is not sufficient theory and observation about what this stuff is doing and
Mhm.
how to understand it with like some depth. And I really think like psychology and the mental health professions could do a lot with what's happening in society to start to articulate these things. It's just disappointing how little the field actually, it seems like they're not maybe it's anything connected to the university just has a hard time innovating.
Mhm.
And people are like, no, 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 I'm a specialist on early childhood reading. I can't possibly think about phones. I only do early childhood reading interventions. That's my whole career. And so people are very resistant to venturing into unexplored terrain
Mhm.
and to say, no, we need to start somewhere. Like let's describe some observations and get some theory down. It doesn't matter if it's wrong. We're starting a conversation here. It'll definitely be wrong. Like it'll definitely change. That's how this works. Like no first stab theory is going to be there intact in decades if it's actually researched. Like, but that's okay. That's fine. That's like
Mhm.
how it works.
Well, it seems like a lot of life is centered around the balance between and the tension between the need for permanence and the need for flexibility. And, kind of going back to even the ego, as you were talking about, the strong ego versus the rigid or the weak. But there's this strength implies the ability to grow and have flexibility. And, with institutions like university, they become rooted in their permanence, which kind of undermines their ability to grow and change. The need to self-sustain is there. And so we end up letting go of what could possibly grow from that.
Well, and everything goes so slow and people are so cautious.
Mm-hmm.
Like I feel like right now it's like, oh, an academic is getting on a theory about sort of what's this a anybody can kind of say phone use correlates with X. That's not a bad study to do and it's good data to have. But like why? What's happening here? Get a theory about what, how, when, why, and in psychologically sophisticated terms, and just get it down. And it's like, a professor will start thinking about that, and we'll have something published on that in about 5 years, and we'll have our first, good theoretical paper after like the phones are already gone and we're using augmented reality glasses and it's totally irrelevant by then or something like
Mm-hmm.
there's not the ability to kind of like do useful, innovative research on the fly in a timely manner is just like not there.
Have you found anybody who wants to write about that for the Open Therapy Journal? And I don't know if you want to plug the journal a bit because that's a really
Yeah,
great publication.
thanks. Well, we have our new issue should be coming out in a few within the week. So yeah, we are interested. We want people who have some type of maybe there's some exceptions we could make. Typically, we only publish people who have a degree in a mental health related field. They're um, they have a unique format in that we want them to be scholarly, rigorous, and have like academic sophistication, but we want them to be accessible and useful and timely. So it has this kind of balance between an accessible, succinct, timely article, which might be more like a newspaper or magazine article, versus like it does reference. It has citations, it references theory and stuff, and it's
Mhm.
written by people who have expertise. So it has that scholarly rigor. And the reason why we're doing that is we really want to spark conversations about this. And we think we need to engage with the public, not just academics. So they tend to be really succinct, packed with information articles that should be accessible to non-experts, but they're written by experts. And every article is on some issue that's been neglected in mental health because of some type of bias. And so we've got a lot coming out in this next issue. I would be curious about what people would say on this topic. The key is we want lots of useful, novel insights, not generic, this could have been written by ChatGPT stuff. Because I
Mhm.
think a lot of times the impact would be like technology is really changing things and like that's really impacting us and we should really think about it. That kind of broad, vague, uncontroversial thing with
It's not
nothing added.
helpful.
We're not you put a theory together that's useful. We're primarily focused on socio-political bias, although I would do something about phone use or drug use if it had the right angle on the socio-political and a connection to bias in it. I think I would be interested in that, but it's like it would have to really highlight some insights. And if anybody who's interested in doing something like that can go to our website, opentherapyinstitute.org, click on the journal page. There's a portal for people to put submissions in. Um, but novel, useful insights that are
Mhm.
succinct and not, not the vague, generic stuff. And so it's challenging, but yeah, anybody is free to contribute.
Excellent. Well, thank you for a great discussion. And, since we're talking about Open Therapy Institute, I'll just also put in a plug for the member groups
Okay.
because we have member discussion groups, peer consultation, and the kinds of things we talk about are often similar to the sorts of things you and I talk about in these recordings. So it's a space to really get into anything from more concrete, this is what's going on, to the more broad and conceptual with other people who are thinking openly. It's for practicing therapists, and so I
Yeah,
think
and I would
people are interested.
really like in terms of like getting the membership growing at OTI, we're so dependent right now on word of mouth that anybody who's a member sharing it, people who know about it, joining it, because we kind of have this kind of nascent movement. We have hundreds of members. We really want to grow into the thousands of members. And right now, every sign up counts. And I think people who attend the groups tend to really like them and benefit a great deal from them, connect to other people, get therapy referrals, get CE credit workshop discounts. There's lots of benefits to it. But we're really, if you value this type of thing, please become a member and share it with as many people as you can who are professionals in the field so we can grow this community.
Absolutely. Well, thanks for a great conversation, Andrew. And thanks everybody for watching. Please feel free to comment if you have comments about psychiatric drugs, psychedelics, phone use, any of the topics that we dipped into today. We always
Right.
love your feedback. Thanks so much.
Yeah. Thanks.